Welcome everyone to TUFH's first virtual regional conference for the Conference of the Americas in 2022. Bienvenidos a todos a la primera conversación de la Conferencia Regional de las Américas. First, in the bottom of your screen, there is a globe that allows you to choose whether you want to receive this in Spanish or English. Primero, abajo en tu pantalla debe ser una círculo, un globo que puede indicar si quieres recibir la información en inglés o español. Now I will move forward just in English. So first I want to thank our sponsor, the Pan American Health Organization, represented here by Jose Garcia Gutierrez, our co-host Northern Ontario School of Medicine, and our partnering organizations Beyond Flexner Alliance, Universidad de la Sabana, and the National Center for Rural Health Professions. And I want to thank the organizing committee members who have made this conference possible. Today's program is very simple. We have two fantastic workshops for you. One is Education, Accreditation, and Quality, a Partnership for Change. And the other is a Global Competency and Outcomes Framework that will be presented by Servans Fitzpatrick from the World Health Organization. And with that, I will turn it over to our first workshop presenters.
Thank you very much, Nick. Can you see my screen share here?
We can.
Good. And thank you very much for everybody and the organizers for having this. Today, I'm Bob Willard. I'm a professor of family medicine at the University of British Columbia in Vancouver, Canada, where I hope I'll see some of you in August at the TUFH 2022 meeting. Today, what we wanted to put before you is a reflection on the way in which accreditation and social accountability, when paired, can lead to a positive outcome in terms of the population and people's health, and for that matter, the health of the planet. And that's the audacious thing. And I'm going to very quickly try and set the stage so that we have some commonality of language that we're sharing. And I want to set that stage fairly quickly. And then Jose is going to take that into the next stage of context, but we want to spend the bulk of the time with what amounts to a case study of the Northern Ontario School of Medicine, because what we're undertaking, and each of us is here today instead of with our families or in our work or whatever, we're all here today, I think, because we want to build a better world, and so that being the case, it's again an audacious dream for us, but we want to see about using social accountability and accreditation as a fulcrum, as a way of bringing about that change, to animate, as Northern Ontario School of Medicine does, the role that a medical school can make in partnership with others to actually have an enduring impact on the health of the people. So let's just very quickly dive into the idea of social accountability. And we're going to, I realize there's a tremendous amount of detailed discussion about social mission, et cetera, et cetera. We're going to keep it simple with using the 1995 World Health Organization definition of the focus of the medical school to use its various activities. What's often left out of this definition is the second part, which is the partnership that's necessary in order to bring about change, in order to translate, as I hope we're going to talk about today, good intentions into effective action. And that partnership has been outlined by the World Health Organization as 5 partners, and it's the cross-linking of all of those partners. And I'm not going to go into great detail, but it is important to have all the partners at the table. Otherwise, we just blame whoever's not at the table. We just say, oh, there's not enough political will. We just say, oh, health professionals are greedy. We just say that there's too much red tape and bureaucracy. All of those become excuses for failure. We need to remember that those partnerships exist all the way from the village level to the national level and beyond. So within that concept of social accountability, as we imagine moving this agenda forward in each of our venues, let's keep in mind the partnership that's necessary to translate good feelings, good intentions into good actions. Accreditation is too often seen as an auditing function. Properly used, properly developed, it can meet Archimedes' wonderful statement that give me a lever long enough and a place to stand, and I can move the world. And I think that should be, in a sense, our main animation in terms of using accreditation. It's its function moving us along that. And let's think about accreditation not as a bunch of auditors that come from outside, fill a bunch of tick boxes, and then give you a piece to put on your wall for the next 5 years until they come back again. That's a counterproductive exercise, and very often, because we need innovation more than ever, very often accreditation is seen as an impediment to innovation rather than a facilitator of innovation. So let's take it back to the individual level and think about a profession and what it is. And think about how the accreditation process might be looked at as analogous to what we think about as professions. So a profession is responsible for stewardship and application of a particular bank of knowledge. It carries an obligation to use that knowledge for the benefit of others. That's why we're here today. That's what animates each of you, I'm sure, as you get up in the morning. That's a social contract that a profession has. And in a profession, we demand of each other effective lifelong self-reflection, looking at ourselves. Is it as good as I can be? Learning. Do I know as much as I need to know in order to be of optimal service? And peer review. Am I just being delusional? Are my good intentions simply convincing me that my work is good? And so, in a sense, although accreditation might be simply defined as a system whereby an institution or a program is assessed for its compliance with predetermined standards of structure and process, let's move beyond that and think about it as institutional peer review. The development of the report to an accrediting agency is self-reflection. The acceptance of that as an accurate reflection is important. And that's where I want to do it. Now, I want to spend just a moment thinking about, okay, that's nice. So what? So what? If we are, and I apologize for the quality of the slide, and I want to acknowledge this comes from work done in Indonesia, and it represents thinking from that wonderful nation. If we think of ourselves here and the status quo here, and we can't accept the status quo for various reasons, which are increasingly obvious, then we need to have improvement and we need to have innovation. Improvement just means doing the same thing better. Innovation means doing new things. Those are challenging things to do. And what's really challenging is moving actually across this diagonal axis. So we improve and innovate. And that's where the reassurance that society and ourselves might gain from the accreditation system is that it's moving us in that direction. So, global things, global change. Why did we arrange this particular session the way it is? Because of the common phrase, the devil is in the details. Or as Albert Einstein beautifully modified it, God is in the details. Whichever path you want to take, the point is that rhetoric is relatively easy. Intentions are often expressed, but how do they get translated? And that's why we're going to delve into a case study. And I hope that everybody, as part of this webinar, is reflecting on themselves, reflecting on their situation, reflecting on how some of these ideas might be done Why is that important? Well, when we undertake a complex task, I often think we undertake 5 Ds and a G. You say, well, what the heck is that about? Well, we have a desirable end. We have something that we want to achieve. In this case, a socially accountable accreditation system that's going to lever change in the healthcare system. If somebody doesn't believe that can be done, they're not going to start down that path. And the smoking cessation and other literature tells us again and again, if you don't have hope, if you don't have a sense that you can get somewhere, then what happens is you just deny. It's not a problem. You know, we're doing social accountability. Everything's okay. Or we say, well, that'd be nice, but we don't have the money, we don't have the partnership, we don't have anything like that. And so we fall into despair and even institutional depression, where we're surviving rather than thriving. And so what do? We feel guilty. And guilty is the best stance if you don't want to do anything. So the key is it doable? And when you link desirable and doable, which is what we're talking about here and what my colleague Aaron is going to talk about later, when you link that, then you translate to positive action. So we're hoping that that you will think of the narratives we're going to be talking about now, spend some time reflecting, sharing, and then we'll come back and talk further. So I'm going to turn it over to Jose now.
También cambiamos de idioma. Buenos días a todos, es un placer estar aquí y en un grupo pequeño pero muy selecto y tocando además un tema que para muchos de nosotros es de suma importancia. Siguiendo el discurso de Bob, quiero hacer unos comentarios rápidos sobre los dos mundos que van juntos pero están separados a nivel global y regional relacionados con la acreditación y con la misión social, el social accountability por otro. Y llamar la atención al grupo sobre una serie de situaciones que se están dando en este momento. En el mundo de la acreditación, por ejemplo, tenemos que el año pasado, a finales del año pasado, aparecen los nuevos estándares que la World Federation of Medical Education, la Federación Mundial de Educación Médica, propone para la acreditación de las escuelas de medicina, en la cual no hay un apartado ni referencia clara hacia la misión social. Algo que quiero llamar la atención por ponernos en el momento actual en el que nuestra idea se enfrenta a la realidad. Por otra parte, la Federación Mundial también inicia un proceso de establecimiento de una serie de institutos independientes que se van a encargar de la acreditación a nivel internacional de las escuelas de medicina que lo solicitan. Y esto establece una doble dinámica en el mundo de la acreditación, en la que tenemos por un lado en muchos países las agencias nacionales de acreditación y estos institutos que se mueven en muchos casos a nivel regional. Esto ocasiona una serie de situaciones extrañas dependiendo de las diferentes partes del mundo en que nos movamos, incluidas las Américas. Esa es una parte del contexto a nivel global, algo que quiero llamar la atención. El segundo, refiriéndonos a lo que pasa en las Américas. Y en las Américas hay dos situaciones que yo quiero diferenciar. Una es lo que los latinos llamamos los vecinos del norte, que es la situación que existe en Canadá y en Estados Unidos, y lo que sucede en Latinoamérica y el Caribe. Entre los vecinos del norte, y vamos a tener luego oportunidad de oír la experiencia de Canadá y un estudio de caso muy específico relacionado con una facultad de medicina, pero por otro lado tenemos la situación en Estados Unidos. Y en Estados Unidos quiero también llamar la atención que en el mundo de la acreditación, y esto tiene una repercusión a nivel generalizado, el IFMG sigue con su propuesta abierta de que va a reconocer la entrada de médicos que quieran trabajar en Estados Unidos solamente en el caso que vengan de facultades de medicina que han sido internacionalmente acreditadas y ha movido su raya o su línea del año 23 al 24. Pero esto es una iniciativa alrededor del mundo de la acreditación de las escuelas de medicina, en este caso, que sigue condicionando una parte de las actividades que suceden no solamente en nuestra región, sino a nivel general. Por daros un ejemplo muy concreto, deciros que en la región del Caribe, el Caribe americano, el Caribe inglés, como se suele llamar, hay 94 escuelas de medicina, de las cuales solamente 4 son públicas. El resto son facultades de medicina privadas, que en muchos casos, o en casi todos, son outsource de instituciones de Estados Unidos y que están obviamente muy interesadas en ese reconocimiento, esa acreditación para que sus estudiantes puedan volver a trabajar a Estados Unidos. En el Caribe solamente existe, y esto es un modelo interesante, una agencia de acreditación para toda la región del Caribe. Y esto está generando, como podéis imaginar, una serie de movimientos y del establecimiento de prioridades relacionadas con la acreditación. En el caso de Latinoamérica, y tenemos la suerte y la oportunidad de que luego veo entre los participantes gente que espero que participe desde México, desde Brasil, desde Argentina, Colombia, y por favor ellos pueden elaborar mucho mejor la situación de la acreditación en sus países. Estamos viviendo una situación absolutamente heterogénea, en las cuales hay incluso países en la región que no tienen una agencia de acreditación. No hablo ya de escuelas de medicina, sino de acreditación de la academia o de acreditación de la educación o de las instituciones educativas. Hay países, como algunos que se van a ver, en los cuales no existe un sistema específico de acreditación de las facultades de medicina, sino que existe a nivel general un sistema de acreditación de la universidad global, y si la universidad queda acreditada, se acredita la facultad de medicina. Existe una gran heterogeneidad. Y quería llamar la atención sobre esto porque lo que nos ha traído a esta reunión es algo que va mucho más allá de esa idea, que no podemos ignorar. Es decir, lo que estamos tratando de seguir moviendo después de 2 décadas de mover la idea del social accountability, una década en la cual muchos de vosotros y muchas de vuestras instituciones están empujando la elaboración de estándares, de indicadores, para tratar de movilizar el avance de la idea. Lo que estamos tratando de mover es que, en base a lo que Bob decía, de aumentar la equidad en salud, el llevar médicos y profesional sanitario a esas áreas, en este caso de nuestra región, que es donde nos vamos a centrar, de las Américas, donde, por daros algún dato, más de 100 millones del billón de personas que viven en esta región, es decir, 1 de cada 10 personas, no tiene dónde ir a que le atiendan ni nadie que les atienda. Detrás de la idea del social accountability está cómo llevar profesionales sanitarios a las zonas rurales, remotas, urbanas desatendidas, etcétera, etcétera. Y ahí es donde, mientras no aparezca una nueva idea, la idea de la misión social sigue siendo para muchos de nosotros, y es lo que tenemos que seguir defendiendo, y es por lo que estamos aquí, ver cómo seguimos empujando esto con nuestro compromiso y con nuestro trabajo. Pero existe algo que es realmente muy importante, que es cómo trabajar la idea de la misión social para incrustarla dentro de esos sistemas de acreditación que yo estaba comentando, y que es un mundo en este momento muy revuelto y muy controvertido, para que haya países y experiencias como la canadiense, que por eso creo que es tan importante este webinar, para actualizarnos en el único país que yo conozco en el mundo que tiene 17 facultades de medicina, todas ellas públicas, y que además ha logrado por primera vez introducir la idea de la misión social dentro de los procesos de acreditación, con un acuerdo de las facultades y de las instituciones acreditadoras. Y por eso creo que es tan sumamente importante compartir la experiencia canadiense como un modelo para tratar de seguir avanzando. Y como Bob decía, esto no es una cosa fácil. Si hubiera sido fácil, no estaríamos aquí, porque estaría hecho. Lo que sigue siendo realmente importante es cómo la gente que estamos comprometidos con esta idea podemos conjuntamente seguir avanzando, ¿eh? Así que muchísimas gracias a todos por unirse a la conversación, que esto es un inicio para seguir dentro de la región avanzando, y le doy la palabra a Erin y le agradezco mucho el que pueda compartir con todos nosotros la experiencia que han hecho.
Thanks, Jose, and thank you, Bob. It's such an honor to be able to present both with Jose and Bob. You can clearly hear their passion for this work, and I think again, together we can make a difference and change. And I think the example of Canada, the example of NASM, is a great case study of this very thing. Working together, it can take time. But when we, as Bob had said, when we can focus on improvement, so improvement of quality, but also focus on innovation together, really that's where we're working towards. And so, so my task today was to give a bit of a case study of NASM University, or the Northern Ontario School of Medicine. Who am I? So my name is Erin Cameron. I'm the director for the new NASM University Center for Social Accountability. And on one of our kind of priority topics is really around accreditation, because it's such, as Bob started his talk about, was it's such a fulcrum. It is such a lever in terms of advancing change, and hopefully that will kind of become clear today in terms of the Canadian context, and has really helped to advance NASM, but also the Canadian context. So why NASM? So NASM was established in 2005 and has been rooted in the North. Jose talked about, again, looking at the disparities, but also the human health workforce that we need to be working towards, because there's so many gaps. And in Northern Ontario and Canada, there was a huge gap. And so the Northern Ontario School of Medicine was founded on social accountability. And it was founded in our patent letters to be able to say, this medical school is based in the North and serves Northern Ontario. So it directly serves the patient populations, which was so important. But part of that was, it was co-designed, co-created, and co-imagined. It was the people of Northern Ontario asking for this. And so, like roots of a tree here in this image, the tree, where does the tree stop and the forest start? Really, that interconnection is so important to when Bob talks about that partnership pentagram. So when you start to look at it, and I'm sure some of you, and if you'd like to hear more about NASM, I'm just providing a very high overview today. But when you start to look at the school itself, there was a structure designed that was distributed in nature, but also really from day one about community. Community said, what do we need in a doctor? And here are the very things. And in terms of meeting accreditation, so it was like accreditation plus. It was, here are the kind of basic requirements of the program, but what do we want this school, and what are those additional needs within the school to meet our human health workforce needs and our future generations. There's partnerships of over 90 communities, so it's so much about partnership. Again, and the priority populations in Northern Ontario are Francophone, Indigenous, and rural and remote. I think most recently, what's been really exciting is now we are also independent. So it's NASM University. We are now an independent university charting this territory, but being able to then partner with many institutions across the North. So again, this might be familiar. Bob already showed the partnership pentagram. There's also a partnership pentagram plus. There's other partners. You know, I think as we walk forward in this work, recognizing who needs to be at the table and who's missing. So that conversation about who. But that framework of, and I think this is something very familiar to many of you, is what are those needs? And this is what social accountability is all about. What are those needs? How do we respond to those? And then how are we measuring that? And that cycle again, priorities, action, and then measurement, and kind of that outcome of, are we having an impact in what we're doing, is so important. So when we start to talk about accreditation, so not only social accountability of addressing the priority needs, but the fact that it took a long time, and Bob was one of the champions. There were many, but again, this work takes many to be able to actually put it into the accreditation standards in Canada. So looking at those who were involved in the progression and expectations of social accountability. There were white papers, there were vision documents, there were many, articulation of why this is so important. And Jose, you spoke so eloquently about this, why this work is so important. And not only that, but why we need to be working together, not only regionally, but also nationally and internationally, to be able to share our successes, but also our challenges and what can we be learning, but how we can be learning from our different contexts and experiences. So in 2017, the National Social Accountability was put into our accreditation in Canada. And this is what it reads, and I will read it out loud because I think it's really important. A medical school is committed to address the priority health concerns of the population it has a responsibility to serve. The medical school social accountability is 1, it's articulated in the mission. 2, that it's a part of and fulfilled within the education programs in the curriculum, content, types, and locations, and that it's also evidence in the kind of outcome measures of the school. And the schools can determine those. I think where we're working towards now is moving also beyond this. What else needs to be there? This was an incredible starting place to get it in there. And not only is it now up to NASM because we were founded on it, but it's up to all medical schools to move this together. And I can tell you nationally, there are groups working on this. We have a national network of those who are involved in this work that we meet regularly every year. I co-chair that group, as well as now, and I think what's so exciting is social accountability within accreditation is growing. It is now one of the pillars of the new strategic plan of our faculties of medicine nationally. So social accountability is a key pillar of that work. And so now there's a standing committee nationally of this work. So again, I think from a network of people who are passionate about this work to now a core committee working on this nationally to share that. And it looks very different in different medical schools. So NASM, I can share with you, NASM was founded on this. It's in everything that we do. And I will share some examples of how we're implementing this, because I think, Jose, the idea of what does this look like? How are we doing it? And I want to give you some tools in terms of things to think about. But I think every school is different. There are different positions. There are people who are, that is their work, that is their role. There are centers. It's embedded in all that we do. And so there's different ways of articulating this. But to have this as an accreditation standard, it is an expectation. And I think that's been a huge plus within the Canadian context. So I did want to braid together how we are starting to think about at NASM. In 2005 was our first intake of students. So when we think about the medical education program, producing future socially accountable health professionals, but we have to think about also the healthcare service delivery. Where are they going to work? They're going to work in these contexts, and actually starting to look at how do we change those service delivery spaces like hospitals and contexts where our students are going to be learning. So again, it's gone from the program to the healthcare service delivery to health system transformation. So how are we transforming the system? And I'm going to share just a few examples. And then research and really action research. So thinking about how are we changing policy? How are we using data to really bring to the table of policymakers and saying this needs to change? So being that voice collectively. And then also the drivers for change, that fertile, that image of the tree, that fertile ground, how are we helping to grow that transformation, and also how are we starting to look at it? I think so not only do, NASM participates in the accreditation standards, and we just underwent the UME accreditation, so the undergraduate medical education, which is our MD program. We also participated recently last summer in the ISAT. So the Indicators of Social Accountability tool, I put the link there. If you haven't heard about this, was a global pilot that says 2011, that should say 2021, my apologies. And 10 schools participated in this. And it was launched at the TUFH conference, but it's a collaboration of PAHO, the NET, TUFH, Beyond, Flexner, many partners at the table have worked on this and collectively have put a lot of work into this that really captures the breadth of the components. And I'll just highlight some of them. So again, students, who are you admitting into your program? Again, the tool, which is very much, as Bob said, a self-reflection exercise. It's very much a chance to look inwards, and Nazem actually, after passing accreditation, then used this tool as a way to then say, where are we going? So where do we also want to continue to improve? Because again, it never ends. I think that's part of the social accountability, is that we're always working towards meeting the priority needs, and those change. So what are we doing to address that? And so we use this tool to do so. So, but quick questions to think about: students who are coming in, what students are coming into the program, faculty, who are your faculty teaching? Does it represent the diverse context in which you are in? The curriculum, so not only the content, but how is it taught? What are those teaching methods? Research, what types of research? How is it done with community, in community? Governance and outcomes and impacts. Again, I encourage you to go look at the tool. It's being now, many institutions are reaching out, and I know many of you also probably participate in it. I did want to mention there is a deadline for the new intake of the ISAT, June 30th, and the focus and the emphasis over this next intake is going to be Latin America, which I think is very exciting. But it's a really incredible tool to be able to be self-reflexive as an institution. So as Bob said earlier about the peer review process, but also a reflexive process institutionally, it is a wonderful tool to be able to do that. And we've now embedded the ISAT tool within our kind of accreditation processes ongoing annually. So I think, again, there's a way to embed it. Stepping backwards in terms of health system delivery, again, I think it's so important to be in the system. So Dr. Alex Anawati, who was one of our charter class, now has been working in the field for over 10 years and says, it's great that it's in medical schools, that we have this framework within medical schools, but we also need to be changing the context and the healthcare system that we're in. And so he's been working on a tool similar to the ISAT tool, but now for healthcare institutions. So in terms of a socially accountable health professional, you've got then graduates out in the system, you've got kind of the practice of medicine and the delivery. So this idea of a socially accountable healthcare delivery system is something he's working on, and a tool that he's building and validating right now. I did want to mention that where he is validating this tool is in, and I believe it's one of the first hospitals or institution that actually has a VP or vice president of social accountability. So someone within the hospital leadership, who that is their role, is social accountability. So again, that kind of embeddedness, which I think is so incredible, and they're looking to build on that work, and it's part of their strategic plan. So again, that beautiful marriage of Nazem University graduating students into a system that also imbues and embodies social accountability. The other latest in terms of going from kind of medical education programs, tools to support that process, delivery systems and tools there. And there are others. I'm just mentioning the three that we have used in the last little while, but I think there are others. And we can talk about those potentially in our small groups. But I did want to also talk about health system transformation. And one of the things that Nazem University has taken on over the last year is that we've established a new center, a center for social accountability. So this is really the coming together, the bringing together of not only the impact, the advocacy, and the policy, education, and research. And as part of the center, there are communities of practice or groups, networks that are really trying to focus in on what data we're collecting, how can we use that, and how can we link that to education. So we've got the Primary Care Research Network, the Medical Education Research Lab in the North, and also kind of this growing focus on accreditation, this fulcrum of how do we start to create change nationally as part of this work as well. So just to kind of very briefly highlight that again, it's all about kind of when we're starting to look at impact, when we're starting to look at how are we measuring our impact, using research and quality improvement in the education field, having access to the data so students and graduates and physicians can work with that data. We also are working kind of across Canada to be able to link data within our medical schools to go from admissions to success and outcomes. So again, that link, data is a big part of this. So how can we support that and understand that what data are we collecting, what are we not, and how can that help to support our future growth? We're also the North network. It's using de-identified primary care EMR data. So in terms of being able to say, how can we learn about care today so that we can change tomorrow? Which is such an exciting, again, way. And these are primary care physicians, so family physicians within their clinics and using patient data that's de-identified, that is confidential and safe, and being able to look and link that to education, but link that to social determinants of health, link it to patient outcomes, and how can we be using that to be able to, again, improve our practice. And then lastly, just to kind of talk about and loop it back to accreditation, is trying to start to work also on accreditation scholarship. So we recently just undertook an evaluation study where we were looking at case studies. So 2 different contexts. They rolled out a virtual accreditation. And so what was so interesting from that work is that context and place is very different virtually. So again, how can we think about that in new ways? What questions can we bring to the table? What programs, graduate programs, training programs can we start to think about together in terms of accreditation scholarship? And lastly, in terms of an international steering committee, the Canadian held a number of sessions, workshops, international workshops that Bob and Charles Boland led, and it was a think tank about what do we need to do to move forward. And so that has morphed into or transitioned into an international steering committee with 3 main thrusts and work. And that was really, again, what was heard from these think tanks was there's 3 key areas. One is standard settings. What can we learn and work together in terms of what are those kind of those standards that we can put forward together to advance social accountability? Advocacy, what do we need to be doing to advocate and support, as Jose very eloquently said, talked about earlier, in terms of social accountability and accreditation. How do we advocate for that at a global stage, using our kind of successes nationally, our collective voices to be able to support that work? And then building capacity, what tools, frameworks, research, what action do we also need to support kind of the standard setting and advocacy? So the 3 working groups, and I know there will be further talk about those, but if you're interested, if anyone's interested to join, be part of that work, work is ongoing and it's very exciting. So just to loop back, I have shared braiding the story, braiding the sweetgrass, my daughter's long hair, braiding these threads throughout, I think, accreditation, from the programs that we do to the systems that the students go and learn from and work in to the I think if we can start to think about kind of accreditation broadly, that innovation as part of quality is really critical. So I think that's where I hope I've shared enough detail. It's a little bit like Goldilocks. I hope I've shared enough details that you kind of are starting to think about different ideas, but not too many details that I have gotten lost. So just a huge thank you for that, and happy to go into future, into more details. But I know we wanted to have the remaining part of the session as part of a discussion about these 3 questions, and I'll put them forward and then I'll turn it over to Nick. The 3 questions we wanted you thinking about today were: what would support building capacity for social accountability in your context? What standards would lead to improving social accountability in your context? And then lastly, what kinds of advocacy is most needed to advance social accountability in your context? And all related under the umbrella of accreditation. Again, how can we be moving the lever forward in this conversation? Nick, over to you.
And Erin, how much time do you want to give them in their breakout groups, whether they pick, how much time do you want to give each breakout group?
You tell me, how much time do we have?
You have about 30 minutes left.
Okay. So I think if we did 20 minutes in the breakout groups,
okay,
or 15 minutes, does that sound good, Bob and Jose?
A ver,
Sounds good.
Sí. A ver, solamente una pregunta. ¿No abrimos una sesión plenaria de discusión antes de ir a los grupos o cómo hacemos?
Jose, I think
The thought, I think, was that we would go into small groups, deal with these questions, and come back into plenary in 20 minutes. But we're open to suggestion.
No, I thought that we agreed that before going to the groups, maybe some people will like to make some general comments about the experiences and that before going to the groups. That's what I thought we were doing.
We can do that.
Just in case, because we will be discussing specific issues in the group. So if somebody went to make general comments about the presentations and, I think that it will be a good time to do it now before going to the groups. Just in case there's somebody.
So let's open it up for general questions or comments to any of the presentations, Bob, Jose, or Aaron.
Okay.
Melissa, you want to go ahead?
Yes, thank you. Excellent presentations. It really gives a lot of food for thought. I just had a comment. So one of the things when we were reviewing, when we were doing the ISAT, just a really small comment to mention is social accountability is not social responsibility. And so when we do the translation, I think it's very important here in the session, when we translate to Spanish, to not translate it as responsabilidad social. At least in our community, and we can maybe look for a better, obviously, a consensus as to what terminology we could use. But we use rendición de cuentas. And I think it's very important to not, to use the proper terminology, because if we're looking, to be able to for instance, to give objectives and to be able to study and to really say what social accountability is, we cannot keep using the word responsabilidad social in Spanish, because they will cause further confusion. It could potentially cause further confusion. And you really have to go into literature and to be able to know about the subject, which not all institutions, I think, were all up to date on that. And so that was just a comment. Thank you.
Melissa, let me thank you for making that distinction. And in French, it's also a challenge. Charles and I have written that there's social responsiveness, which is basically a extension of intention. We try and do better. Basic responsibility, which is a kind of a reactive thing to try and bring it in. And social accountability is, as Aaron elegantly demonstrated, is about actually measuring impact. Are you achieving what you thought you would achieve? It's the step beyond good intentions to showing it. So thank you for underscoring that, and thank Erin for weaving it into her diagram. Larissa.
Larissa, you want to go ahead and ask your question or comment?
Sí, buenas tardes. Más que hacer una pregunta es hacer un comentario. Voy a hablar en español porque total hay traducción simultánea. Lo siguiente que quería comentar en relación a lo que dijo Melissa, bueno, esto fue discutido mucho tiempo. José, con él hemos discutido en un consorcio sobre social accountability que hemos intentado organizar en universidades en Latinoamérica, y lo hemos traducido en su momento como nuestra misión social en realidad, porque también rendición de cuentas apunta mucho para algunos países con la cuestión económica y de cuentas y de dinero, y entonces en realidad es una misión que tenemos como facultades de medicina de generar un impacto en los sistemas sanitarios de nuestras regiones. Con respecto a esto, quería comentar que, bueno, yo en este momento ya no soy más decana de medicina, estoy como vicerrectora en la universidad, pero fui durante 8 años decana y 8 años secretaria académica en una facultad de medicina de la República Argentina, que es en la Universidad Nacional del Litoral. He participado también en este proceso de implementación del ISAT dentro de estas 9 universidades que hemos participado primariamente en esta implementación. Y quiero decir que en este momento en la República Argentina estamos en un proceso de un nuevo llamado a acreditación de las carreras de medicina. Este nuevo proceso de acreditación de las carreras de medicina se va a realizar con un nuevo instrumento de acreditación, que es un nuevo pool de estándares de acreditación para las carreras de medicina. y por sí mismo, conceptualmente, el concepto de misión social, social accountability, o como le querramos poner, no está mencionado como tal en ese nuevo documento de acreditación. Simplemente habla de escenarios de prácticas donde además se incluya los espacios comunitarios, además se incluya el primer nivel de atención, pero no se habla específicamente de una orientación que tiene que atravesar todas las funciones sustantivas de la universidad. Por ejemplo, tenemos una misión social también en lo que investigamos como Facultad de Medicina, tenemos una misión social también en cómo nos vinculamos con el afuera, y eso no está completamente transparentado en ese instrumento. Por lo cual, escuchando lo que decía Erin, estoy de acuerdo con que tenemos que reforzar nuestra acción como multiplicadores de estos conceptos y multiplicadores en nuestra función de advocacy, de llegar más allá desde nuestros lugares a que se comprenda, porque muy probablemente es que tampoco se comprende el alcance del concepto de social accountability en nuestras instituciones de educación superior. Y por eso creo que tenemos que darnos una estrategia, y adhiero a lo que Erin decía, darnos una estrategia nosotros en comenzar a multiplicar fuertemente en la región de las Américas cómo esta idea de misión social tiene que impregnar todas las funciones sustantivas de nuestras facultades de medicina. Porque en realidad a lo largo de los años su presencia ha sido heterogénea, con altos y bajos. Y estamos en un momento donde yo no estoy segura que esto sea un punto alto, sino más bien creo que es un punto bajo. Y en un momento donde realmente deberíamos estar acá arriba por las condiciones sociales y económicas que está atravesando nuestra región, más aún luego de la pandemia. Era simplemente ese comentario.
I think that's, again, very, very helpful contact. And Aaron had mentioned the steering committee for an initiative that is trying to make that jump that you're talking about and trying to recognize the plurality of languages, the plurality of perspectives, but try to bring together, and that's why the three questions that we want to wrestle with is to share our experiences, as you have eloquently shared, not only your personal experience, but the context in which it is there. This is what makes it hard, but it also makes it hopeful to me. The people that are on this call that are going to carry back and bring about change. And I just want to underscore and reinforce, when we talk about accreditation being the lever that can change the world, to again come back as reference as you did to Aaron's point, it's not just the undergraduate medical school. In concert with the institutions of healthcare, we can change the world. So thank you for that. I think Isabel.
Gracias. Primero, bueno, gracias por la invitación a participar en esta reunión. Gracias a José que me invitó. Yo soy argentina, pero bueno, en este momento estoy trabajando en la OPS. Quisiera quizá traer, para reforzar lo que dijo Larisa respecto del tema de la advocacy, creo que me parece que hay que ampliar los socios para ello. Yo he trabajado como directora nacional de recursos humanos en mi país, en vinculación con el sector educativo y con la responsabilidad de tratar de, bueno, justamente de mejorar la distribución y el desarrollo de los equipos de salud en el territorio. Y me parece que realmente hay una... es relevante pensar cuáles son aquellos actores que van a acompañar en este proceso de advocacy, no centrándolo solo en el sector educativo. Creo que el tema del pentagrama me parece que es sumamente relevante, pero digo que creo que en el contexto en el que estamos, en donde hay serias brechas en nuestros países, en todo nuestro territorio. Ayer justamente acaba de ser presentado un estudio muy interesante de una revisión sistemática que daba cuenta de cuáles son las intervenciones efectivas que se han encontrado y el rol que la universidad tiene en intervenciones complejas para mejorar la inserción. Creo que para todo el proceso de advocacy, de mejorar los estándares de acreditación, y digo, con Larissa hemos compartido espacios de discusión en el país, entre instituciones de salud y instituciones educativas, me parece que hay que fortalecer los vínculos con los socios en los gobiernos, con la comunidad, porque realmente no... Este proceso de acreditación y de social accountability todavía no está instalado ni siquiera en el imaginario, pero creo que trabajando con los responsables de la prestación de los servicios, con los actores del Estado, responsables de los sistemas de salud, se puede contribuir a instalar mucho más este concepto y esta necesidad, porque es una necesidad sentida desde los sistemas de salud, que no tiene todos los nombres colocados. Entonces hay que acompañar a colocar esos nombres entre diversos actores de los actores del gobierno, los policy makers, los actores de la comunidad, y que puedan comprender la relevancia de los sistemas de acreditación y de incorporar estos estándares. Yo digo, no sabía que estaba sucediendo esto, que en los nuevos estándares de medicina en mi país no estaba colocado los estándares de misión social, cuando sé que las facultades de medicina han peleado para ello. Entonces, justamente sabiendo que las facultades de medicina intentan instalar estos estándares, y que se escucha mucho a los pares, que estos estándares no están, me parece que es porque hay un déficit en la representación social y en la presión social para que esto suceda. Eso nada, y bueno, un comentario aparte, que es que comparto con José la preocupación respecto de las agencias acreditadoras internacionales, porque sus estándares van a ser estándares que atiendan a otros intereses y no a los intereses de nuestros territorios. En muchos países, yo he trabajado en el Mercosur también, en muchos países hay déficits en las agencias de acreditación en Latinoamérica, pero digo, sí tenemos que tener en claro que pensar en los estándares de acreditación tiene que ser una construcción social de los países y no pueden venir determinados de agencias extranjeras, de agencias internacionales que buscan captar los profesionales que nosotros queremos retener. Bueno, gracias, disculpen.
So Nick and group, should we be thinking about a 15-minute small group session then? I think we can we squeeze that in and then get together again, or do we want to continue on in this vein?
I think it'd be great to have even just 10 minutes, Nick, just breaking out at the smaller group.
Okay, we have about 2 minutes left. I would love to hear from the people on the call. Is the why is it important? Like, what's the motivation for your institution to actually take the first step in readying your institution to move forward with these standards? Because I think that's what we're struggling with. We're guessing what's motivating to institutions, but if there's any insights in terms of what it takes for your institution, that would be very helpful from our perspective. Go ahead, Erwin.
Gracias. Pues en nuestro caso particular, nuestra motivación pues surge del proyecto educativo institucional de la universidad. Y es incluso en una investigación que fue financiada por el Ministerio de Salud y la UPS hace 4 años, se consideró como el primer punto de partida, más allá de las escuelas de medicina, que también es importante, y cuando hay una orientación social por parte del proyecto educativo institucional de la universidad, eso facilita que este tipo de iniciativas se implementen con mayor facilidad. En el caso nuestro, la universidad determinó la relevancia de impactar en el medio próximo, en el entorno cercano, en la zona de influencia, y esto se tradujo a que posteriormente, después de instituirlo en su proyecto educativo institucional, todos los programas, enfermería, medicina, derecho, gastronomía, administración de empresas, tenían que adaptar sus modelos educativos para poder impactar en el medio. Y esto pues nos tradujo en dos elementos: la relevancia práctica de lo que estamos enseñando, eso es una consigna del nuevo rector, pero también la solución de problemas reales, no solo problemas teóricos. Y entonces eso hace que particularmente se facilite ese modelo educativo. Cedo la palabra porque ya vi que llegaron el resto de participantes. Gracias.
Thank you. So we'll turn it back over to Bob to get reports back from the groups.
Okay, could I ask, let's just turn first of all to the advocacy group and see, were there threads there, observations that would be helpful for the group at large? Aaron, is there somebody speaking, or do you want to reflect on that?
We didn't identify anyone. I'm happy to jump in, and then maybe if the group member wanted to add, if I haven't captured something. I think what we spoke about was the many layers of advocacy that need to happen. So not only within accreditation system, but also government with community. So just the various layers that advocacy needs to happen in levels of faculty. I think one of the, and also what came out as well in our conversation was how much the Pentagram Plus drives trust and then drives advocacy and kind of that safe relationships that need to exist to then be able to make change together. So that kind of the relationship role, the trust role. And then we got into near the end, actually talking about quality and what does that term mean, and how do we, whether an academic uses it versus or a clinician uses it, or a system partner uses it, and kind of the different ways we use that term in particular. And so that's something that would be worthwhile exploring more. But how we use that term also is something that we need to watch, that could be explored further. Anything else that I have not touched? Looking at my group members.
You can see why we love Erin. She has this amazing ability to distill complex conversations. She has a future in the Scots Highlands distilling Scotch, I think, if she ever gets tired of us.
Larissa's going to add, because she'll add to my to my summary.
Oh, good. Sorry, I didn't see that.
The need of join or link the concept of social accountability with quality.
Do you want to expand briefly on that?
Perhaps Arnoldo can tell us more about that, because he explained very, very well this link.
Thank you, Larissa. Yeah, I was telling in the group that we have some terms is quality that is function mark on what is the kind of requisition for accreditation and also for the health practices. And they made a lot of strain on what is required, and in the kind of the health system, the quality is mean that they favors the practices on big hospitals and big clinics, and they let out the practice in small settings and in rural areas. We are working on that, and it's very difficult because even for university to get accreditation, you have to show that your students are going to big clinics and you get all the perks. But these together are the kind of extension of health for everyone. You have to put that quality doesn't mean to have the big technical equipments or instruments, but you have to reach out and to get everyone into the picture. For me, that will be quality, because there has been a term used a lot on accreditation, and we have to tell that means quality is to get the means to get everyone. That is the kind of picture, because I say that term has been used also to take people out of the picture. What is quality? What you need to get that quality that sometimes the normatives and the legislation requires to practice or to do the labor of health.
So advocacy needs to embrace the idea of equity and
quality and equity
and quality. But quality, and there's lots of literature on continuous quality improvement and the role that has. Okay.
So we're at time. Maybe you can give 15 seconds to each group to do a quick report back, and then we can move on to the second workshop.
Okay, well, I want to just say in the group on standards was mostly related to how do you embrace within the concept of standards the social determinants of health, the broader influence of health, and how do you embed that in the standards for accreditation. I'll just turn to the main group and see, is there someone wants to report on that, Jose or anybody?
Bob, I'll just say,
muy rápido. Sorry, Bill, go ahead.
Challenge. Yeah, I put it in the chat just in interest of
time. No, go ahead.
We talked about the challenge of large numbers of patients and leaving little room for the discussion of social accountability. I would just argue that it's really a matter of cost accounting. And if you open the curtain and look at the deeper issues, you may actually find that there's more time for patients. I'll just leave it at that.
Okay, that's good. Ese es un mensaje maravilloso. Hay espacio y tiempo para seguir siendo pacientes. Muchas gracias, Bill. A ver, muy rápido del grupo nuestro, que era sobre la formación. Y lo que se ha compartido son dos cosas. La experiencia de una institución que comenzó a moverse en este campo a través de desarrollar programas de competencias comunitarias y trabajo en la comunidad, integrada dentro del plan de estudios y en las prácticas. Y es la manera en la que ellos se han empezado a mover, y que esto además lo están reproduciendo desde una zona en la que trabajaban al país, que es Colombia, en las zonas de frontera ahora con Venezuela. Es una cosa muy específica, muy concreta y que está dentro de ese marco. Y al mismo tiempo lo que compartían era que la ventaja que han tenido de que esto parte como una consigna no de la Facultad de Medicina, sino como una consigna de la universidad como tal y del compromiso de la universidad. Y esto es una cosa que a mí me parece muy importante, salir del espectro de las facultades y llegar a lo que son las grandes instituciones. Y que además la consigna solo no vale si se dice que hay que hacerlo si no sirve para solucionar problemas reales dentro de la comunidad. Y esa ligazón de queremos hacerlo, pero al mismo tiempo hay un problema concreto para solucionar, ha sido la clave de que ellos puedan seguir avanzando. Y al mismo tiempo, la gente de TUFH ha compartido un esquema que me parece muy importante y que se podría discutir en otras sesiones, que es, han estado examinando en los grupos de trabajo cómo avanzar en Capacity Building. Y han hecho 5 estadios que se puede, a ver, que luego Nick en otro momento puede compartir, pero que sería, lo primero es responder dentro de la institución por qué se quiere hacer esto. Mientras ese debate no se dé, ¿por qué queremos avanzar en Social Accountability? ¿Por qué queremos dedicarnos a los determinantes sociales? Y que eso se interiorice en un proceso interno reflectivo, que sería la segunda cuestión. Esto sabemos por qué queremos hacerlo, cómo podemos empezar a hacerlo, que sería el segundo punto, en base a un lenguaje común, que esto es una cosa que si habéis visto de cara a Latinoamérica es un reto que todavía tenemos pendiente, el cómo establecer ese mensaje común o ese lenguaje común en cómo entendernos y esto luego transportarlo hacia cuestiones específicas dentro del plan estratégico de la institución. Y ahí es donde entrarían algunos de los instrumentos que se han mencionado aquí, el AGRI, el DENET, el ISAT, etcétera, etcétera, para finalizar con un proceso de evaluación. Y eso era un poco el resumen que yo haría de nuestro.